you?
How are you?
I'm well, thank you. Nice to meet you. I am cleared to start my FET. What's up, fertility fam? Let's get these babies, ladies. Thanks for clicking on Simply Tanika. I am Tanika. If you are new here, welcome. If you are returning, welcome back. What's up, sis? What's up, fertility fam? All right, I have lots of notes everywhere, and I have puppies who think I'm playing with them. Okay. So I am cleared to start my FET, meaning not the blood work, but let me say that right. I'm cleared to start the process for my FET, not in this cycle, but next cycle. Of course, you know, I gotta have blood work and all that in the actual cycle. But as far as from the reproductive immunologist, I talked to Dr. Vidali at Braverman, who it's his sort of practice once Braverman passed. Anyway, I talked to him today. I'm all clear. I have notes, because you guys have asked me different questions and I've kind of talked about it in some videos. So we're going to make this video and it's going to have all of what's happening with me and the results of my reproductive immunology testing. Okay, so let's, first and foremost, what did they test me for? A lot of you guys have asked me that. So let me give you the rundown. Because I know some of you said, I wonder if I can have my OB take, test me for this. I don't know, girl. I don't know. But I'm going to tell you what they tested me for. So the first, and they're in groups. So the first group is maternal immune tolerance. And it's maternal KIR, uterine NK cells, natural killer cells, haplotype. I'm at higher risk for that. HLA, homozygosity. HOMOZYGOSITY, homozygosity. I'm at lower risk for that. Anti-HY immunity, medium risk, and anti-HLA antibodies, medium risk. I did record what I talked to the doctor today, so stick around to the end so you can see like why I have certain medications that I have, and hopefully it'll tie it all together for you. The second grouping is female assessment, chromosome analysis, thrombophilia, it's either philia or philia, autoimmunity, which I have a medium risk for that. The thrombophilia, I had a lower risk, sorry, and the chromosome analysis was normal. Autoimmunity, I just said that, medium risk. Thyroid, lower risk. Serological, lower risk. Inflammatory was medium risk, but when I talked to the doctor, he said he wanted to treat it as high because I've had 3 miscarriages and 4 failed transfer, well, totally 5, but 4 last year from the frozen. And then metabolic, I had a lower risk, and then nutritional analysis, I had a medium risk, so I'm supposed to be eating like a not low fat, oh my God, low inflammatory diet. Okay, so the maternal KIR, uterine NK haplotype, that was what came up high for me. Then there's a bunch of other tests. Like I said, I'll put it in the doctor's call. He will explain it to you better than I can explain it. I do want to look at the thrombophilia though. Wait, let's see. Is that the one that was a lower risk? Pay attention, Tanika. So actually, let me go back. The one they're looking at is the natural killer cells, anti-HY immunity, anti-HLA antibodies. So what Dr. Vidali had said is mine are borderline, but because of the losses, they're going to treat it higher. Like I'm a higher risk. So the HLA and the anti-HLA active immune. They originally wanted to do IVIG, but there was this big rigmarole with the insurance. It's not going to fly. So we are doing Plaquenil. He said it's just as efficient. The IVIG I would have done 2 weeks before my transfer. The Plaquenil or hydroxychloroquine. Oh my God, I always want to say another medication. The hydroxychloroquine has to start 30 days before. So I did start that on July 1st because I was like, telling myself yes before the doctor told me yes. So I'm out, you know, as of obviously August 1st, that'll be 30 days or 31 because July is a 31-day month, but you know what I'm saying. So let me just go through maternal KIR haplotype, the higher risk for uterine NK cells. What you need to know. Uterine natural killer cells secrete a unique repertoire of cytokines and growth factors that regulate blood vessel growth and development, also known as spiral artery remodeling. And basically, what were his notes on that? So this is I remember now. This was a receptivity issue. So this secretion is modulated based on the type of interaction, activating or inhibitory, taking place between your KIR receptor present on the surface and the HLA-C of your embryo inherited from both partners. So it's receptivity. He said it's more likely that, well, in a long convoluted way, because I already have a child, I'm in a different category. If you haven't already had a child, it may be different for you. So we obviously know that I can carry, but he was saying even if everything was fine with me, there might be something in, because it's my own body, right? It's not necessarily inclined to attack itself, but because of the male cells or the partner, in my case, donor, the body might be having a reaction to it. And he said basically it's like an overactive immune system. Like my body's trying to compensate for defending itself, right? For being attacked is what it's perceived as, like an attack. And so it's defending itself. He said it's kind of good, but I was like, except in this instance, right? But you'll see. And then the other one, same thing. He said that it's basically like an active immune system, like my immune system is being really diligent, which is one of the reasons why the IVIG didn't get approved. That would be for someone who has an autoimmune disease. Like if someone had lupus, they would be approved for that IVIG. However, in their practice, and there are some studies, but the studies are not definitive enough for it to have passed the peer-to-peer review that he had to do. But in some studies, it shows that it's beneficial. So it's one of those things of like might hurt, might help, might help, can't hurt. And the logic is it's treating my body as if I'm having an autoimmune reaction to the fetus, right? So that's kind of what that is. And then the other ones, I just want to look really fast. HLA. And I also had another video that I did with Dr. Thornton, who's my actual RI. So I'll review that too. If it makes sense, I'll throw clips in of both of them because we covered, some of the things were the same, some of them were different. Sometimes one of them explained it better than the other. So I'll cut it together nicely for you guys so it makes sense. So my anti-HY immunity. Healthy women pregnant with a boy may generate an immune response against HY antigens. Male-specific minor histocompatibility antigen. Women with a firstborn boy and carrying HY restricting HLA alleles have significantly reduced chances for a subsequent live birth. As we know, I haven't given birth to a boy. So this patient, me, is at medium risk for triggering the development of anti-HY responses. The patient may discuss her results. So basically, because I'm at medium risk and because I've had multiple losses, they want to aggressively combat this, right? Because we want this next transfer to be that take-home baby. Lord Jesus, name it and claim it. Amen. So, what are the puppies doing? I can hear them. They're like, Mom, why are you panting? So, anti-HLA AB, teeter, titer, I don't know. There's some pictures. I have no idea what these pictures mean. I guess because, you know, they charge you like $2,000 for this report. They want to make it look pretty. They did a chromosome analysis. I have 2 X's, so I'm just a regular female, cisgender. Homocysteine. DNA looks good. DNA factor 2 they tested me for, and PA1 4G 5G polymorphism. Oh my god, I'm making a morphism. 5G allele on top and on bottom. What you need to know. The main function of plasminogen activator inhibitor type 1 parentheses PAI-1 is to decrease fibrinolysis, process that prevents blood clot formation. This test aims to determine if you carry a specific allele that may increase PA1 activity, thus increasing your risk for blood clot and miscarriage. So I am a low risk for that, but they are treating me as if I am not, and so that's why I have the Lovenox, because that's going to thin my blood. It's supposed to help. And he clarified I'm not meant to take the 81 milligram of aspirin, the low dose, until I start my estradiol. So one less pill, but he made up for it with some other pills. The girls are fighting over a toy right now. Please don't knock that camera down, girl. Listen here, look at here, look at here. Okay. I'm not gonna go through this whole report because we did the report on a live, so it is out there, but I just want to give a context for what I'm about to say and so it makes sense when you hear what the doctor said to me, just so it's all in one place. But HLA, autoimmune disease predisposition, so that's the medium, but we're treating it as high. Human leukocyte antigen genes are a cluster of genes involved in initiating an immune response. Some HLA alleles, haplotypes, group of genes are associated with a predisposition to the development of various autoimmune conditions that can negatively impact your fertility. This test assesses your HLA system, which is crucial to determine key mechanisms that may impact your fertility. That's a typo, but you guys understand. So, and it says read more on page 49, but is there a page 49? No. It must be in the supplemental because this stops at page 35. Let me flip through. I should have earmarked these. Sorry, guys. Antiphospholipid antibodies. So instead of taking the, I wasn't going to do phospholipids. We were going to do the IVIG. But so I'm at medium risk. But again, the hydroxychloroquine will address that. Anti-nuclear antibodies, lower risk. This is lower risk, lower risk. Thyroid is lower. So my thyroid, and this is interesting because normally on the labs you get one thyroid number or two. This has like multiples. I don't know if you guys can see that. But I'm all on the lower end for all of them. So the range, let me just see. There's anti-thyroglobulin antibody, thyroid peroxidase. I should call my sister, she knows these things. TSH, which is what I always think of as, so my TSH is 1.16, measured by UG/DL. My TSH receptor antibody is negative 1.10. Or less than 1.10. That must be the bottom of the test. So it's lower than what the threshold of the test is. Total T4 is 7.6. Total T3 is 131. And then I didn't give you guys the number for the top. The anti-thyroglobulin antibody is less than 1. No. Thyroid peroxidase antibody is less. Give me 1 second, guys. I'm going to cut this. I'll be right back. After these messages, we'll be right back. They're in the room, but they're still going. So if you have dogs, I'm very sorry. I'm sure they're going crazy. In the meantime, while I got up, I did get the supplemental, so we can do this reference, hopefully really fast. So we said HLA autoimmune. Oh my God, I feel like a bad mom. I had to take their toy away, but at least they're quiet until they find another toy. Okay, so here's the additional reading. HLA mismatches. Physiology. Human leukocyte antigen genes, commonly referred to as the major histocompatibility complex, MHC, say that 3 times fast, genes, are a cluster of genes present on the chromosome 6 and are involved in antigen presentation to T cells to initiate an immune response. Oh, interesting. Okay. In most cases, this immune reaction leads to the destruction of cells displaying non-self peptides. So you guys know it's a miracle that we can carry babies, right? It's a miracle that our bodies don't just naturally attack it because it is a foreign object. Even your cells are not, it is a foreign object. I know I said it's less likely to attack mine, but it's not unlikely that it attacks my own cells, right? Because it's like, what are you? Why are you here? You don't belong here. I have to protect the human. HLA molecules play a key role in organ transplantation and are associated with many diseases, including autoimmune disorders. While a mismatch in human leukocyte antigens between a donor and a recipient in organ transplantation may lead to a graft rejection, most often due to the formation of antibodies, a certain level of difference between the mother's and father's HLA alleles inherited by the embryo and defined as a mismatch is necessary to actively generate immune tolerance of the embryo. Thus, couples with significant matched alleles for HLA genes may be more prone to infertility, repeated implantation failure, and recurrent pregnancy loss. So that is a good point. I mean, hopefully you understood that, but it just reminded me, because some of you guys are like, oh, what do I get tested? If you are not doing single mother by choice, if you are doing, you're in a heterosexual relationship, you want to get your partner tested too, because you want to make sure you guys are compatible. And also, like with me, I mean, obviously I'm not using my own eggs, but I am a carrier for sickle cell. So when I was of, making baby age, my partner had to be tested to not also be a carrier of sickle cell anemia, because then the child would have sickle cell anemia. So that's just one example. There are lots of others, but you want to make sure you're both compatible. So you might as well go through your fertility testing at the same time. And that was the thing of like getting a match sheet for my donors, also because you just want to make sure there's not an incompatibility issue. So let's see, what is this one? Anti-HY immunity, which I'm also going to be treated for in this next FET. Physiology. During a first pregnancy with the male fetus, we read that. Although present in 30% of women, anti-HY antibodies have been linked to a secondary recurrent miscarriage and subsequent pregnancy or other pregnancy complications such as stillbirth, placental abruption, or fetal growth retardation, which I don't think they say retardation anymore, because what did Cheyenne had intrauterine, it used to be called, it's IUG, or intrauterine growth retardation. That was the old name. I think it's now restriction. Anyway, because retardation is not PC anymore, right? That we don't say that. Anyway, all these events being the results of an inflammatory environment. So I wonder if I was having boys. I wonder if Applejack was a boy. For those of you who are new, Applejack is the baby that I lost from my very first IVF with my own eggs, where I had the miscarriage. Which was crazy because that was like my second miscarriage in about an 18-month period, maybe a little longer, but close to that. Okay, what else do we want to go over? What notes did he go over with me? HLA, anti-HLA, I do like that they give you the supplemental reading. It's not as pretty. I'm telling you, this is where the $2,000 went. You heard? Okay. So Pregmune clinical data. In our practice, a retrospective analysis based on 828 patients have shown that miscarriage rate is significantly increased in patient with at least one HY restricting allele and undergoing an embryo transfer. Oh wow, with at least one. So that is, and then they give you a nice little graph. Absence of HY restricting and presence of HY restricting. So that red are the losses. Or I'm sorry, they're both the losses. The red is the number of losses with presence of HY, and the blue is the number of losses, or the percentage of losses with the absence of the HY. So it's not a guarantee by taking these meds, but obviously it reduces the chances based on their study. Granted, it's a small study, 828, but honey, I'll take it. I'll take it. Pregmune is a test that is created, which one of you guys actually told me, it's created by Braverman, so they're using their own, it's not cohorts, right, because they're patients. They're using their own patients as part of their studies and using that to compile this data and develop these standards, or they're saying these are what their standards are based off of, and here's the data to support it. Okay, embryo MTHFR, I don't have that. So that's, you know, where your body cannot process folic acid, which is a synthetic form of folate. So they tell you to take folate. I take folate anyway because, like, why make my body process the synthetic? I know, I still drink Diet Coke. I know that's synthetic. I'm working on this. Stop judging me. Okay. I think that is all I want to cover. Just let me double check. Yeah, insulin resistance and PCOS assessment. Homocysteine minus 7.8. Hemoglobin. Goblin? No, I'm kidding. Minus 5.3. So that's definitely something you want to get checked too. If you're like, where do I start with my fertility test? Definitely get your insulin checked. Vitamin D. We said thyroid already. Prolactin, that is not in here. So what is my protocol based on those results? I'm glad you asked. This is just my RI protocol, not to be confused with the FET protocol that's coming from the RE, the reproductive endocrinologist. This is the reproductive immunologist. We'll marry them up and I'll be taking all that. But once we get into that cycle, once that period starts and we have day 3, I'll go over that with you guys. So here's what the protocol is. They give me a timeline and then it just says when you are ready to start, keep me posted. I will guide you with the meds and testing. So I will need repeat immune testing, a shortened panel with my first beta, whether it's positive or negative, as it will provide us with information on how your immune system is responding to the embryo and will let us know if we have to make any changes to your immune protocol for your pregnancy or subsequent cycle. Let us know your beta date and we will order the testing. So start fish oil as per your Pregmune report. So this I clarify with him. It starts with 6 grams, which if you saw the other video, you know I'm not taking enough in. 6 grams, which is 6 pills. Each pill is a gram for 2 weeks, then 4 grams for 2 weeks, and finally 3 grams as a maintenance dose, right? Because my fatty acids were very low. The IVIG, Gamunex C, so I'm not taking that. Instead, I'm taking the hydroxychloroquine. But let me just read it in case you are prescribed it, just so you have the background on it. So it would be start IVIG 10 grams. First dose should be a week prior to transfer and continue every 2 weeks. For our indication, since we are using IVIG off-label, it's typically not covered by insurance. We work with various pharmacies that dispense the medication and will set up a nurse to come to your home to do the infusion. Cost of IVIG has been running around $120 to $150 per gram. This is just an estimate, and they wanted me to do 10 grams, right? So about $1,000 if we just do the mid-range of like 100 per gram. So about $1,000 per infusion. Once we send in the script to the pharmacy, they can give you exact pricing. The pharmacy will attempt to get the nursing services provided. So if I had been covered for it, the nursing would have been covered. I should find out. Like maybe I do. No, because that's just money. Let's keep it cost low. But my insurance would pay for a nurse to come and administer the IVIG via IV. Say that 3 times fast. So yeah, an estimate per infusion, if not covered by insurance, is about $2,200. Most patients are on IVIG throughout the first trimester, but pending repeat immune testing, the doctor may recommend continuing longer. If you decide not to use it, Dr. Thornton advised you may consider using Plaquenil. So that's the route that I went. Lovenox. So I'm going to start Lovenox 40 milligrams subcutaneously daily in AM with estrogen start. Injection is given sub-Q in the abdomen to the side of the navel or below. So that was like, there was some other medicine I had to take sub-Q. What was it? Oh my God, I can see it, but I can't. it was already pre-mixed. Anyway, I took it when I was doing my, I gotta do it live in a second. When I was doing my stimulating my follicles for egg retrieval. So expect some bruising and burning at the injection site. 1 week after starting Lovenox, you will need a heparin anti-XA level. This blood test is done 4 hours after your morning dose. It can be done of Lovenox. It can be done at your local LabCorp, no fasting. We'll email you a script. Then prednisone. Start prednisone 10 milligrams by mouth twice daily for a total of 20 milligrams daily with estrogen. Best to take with food. So estrogen, prednisone, and the Lovenox will be all at the same time. Plaquenil I've already started ahead of time. And the omegas I've already started ahead of time. So you will continue the same dosage until further instructions. We wean off prednisone if the pregnancy test is negative or at 12 to 4 weeks of pregnancy on a case-by-case. I'm sorry, 12 to 14 weeks on a case-by-case basis. And then the consent, I had to sign a form saying that I understood that prednisone in early pregnancy has an increased chance of a cleft lip. So I had to sign that. And then calcium, we recommend starting calcium 1200 milligrams daily with the estrogen, and then baby aspirin with the estrogen. With the positive pregnancy test, you will continue all immune therapies. Based on repeat immune tests, we will provide you with instructions on when to stop, taper the medications based on your result. If the pregnancy test is negative, we will provide you with instructions to stop, taper the immune. So that's it. That is my protocol. We are on the good foot, y'all. So stay tuned for the call with the doctor. Junction, what's your function? I am waiting on Dr. Vidali to call me. Hello, how are you?
How are you?
I'm well, thank you. Nice to meet you.
What a nice setup you have there.
Oh, thank you. I'm just working from home today.
You have a beautiful color in your walls. Looks great.
Thank you. Thank you.
Looks great. Looks great.
Awesome. So this is our first time meeting. Is everything okay with Dr. Thornton?
Yes, I've only seen your tests and your images so far.
Okay.
So, and unfortunately, you've been through a lot, right? Because you've had, unfortunately, 3 miscarriages and 5 failed IVF transfers. That's a lot.
Yes. Yes.
You did have 1 live birth. Is that correct?
Yes, a very long time ago.
Okay. And since then, you've been sort of like struggling to get through this.
Yes. Yeah. So I switched to donor eggs last year. So the very first IVF was with my own eggs, and that was the early miscarriage. And then last year I went to donor eggs, and I had
with the assumption that it was going to work, right?
Yes. Everyone was like, "Oh, it's your eggs. There's something wrong with your eggs. We'll get you pregnant."
There's nothing more frustrating when people do the compromise to do IVF do egg donation, and then because it's going to work and then it doesn't work. It's extremely frustrating.
Yes, it is. And it's hard because you transition and it is like a loss, right? You're going to become a parent, but not in the way you intended. So there's already that grieving process. And so you think, well, this is what is going to get me my take home baby. And then when it doesn't work, it's just like,
Oh yeah, it's like a double the pain in a way. Yeah. I agree with this. Particularly traumatic, I would say. Nevertheless, here we are, and you're at Columbia still, right? You're still with those guys at Columbia?
Yes, Dr. McConnell. Yes.
Yeah, and I work with a lot. I used to be at Columbia. Myself as well as Dr. Thornton, whom you've met. Talked to, and we both used to be there. So we're both products of Columbia.
Oh, nice. Did you work with Dr. McConnell? Was she there when you were there?
No, she was before my time, and she may have been there when, because actually Dr. Thornton was a professor at Columbia for many years. He was running their egg donation program, so everybody knows him there. He's very much involved there, I think. He's such a nice guy.
Dr. McConnell speaks very highly of him, so they've worked together. Yeah.
He's a good guy. So, couple of things. First of all, I like to go, I know you've, discussed it with Melvin already, but, a couple of comments about the report immunological testing, right? Because sometimes it can be confusing. People don't understand it. The doctors sometimes don't understand it. But there are some findings in your report that, that do encourage us to, recommend some treatments, right? Like the borderline antiphospholipid antibodies. Do you know what those are? Those are like seen in people who have autoimmune problems.
Right.
And I know values are borderline, which means like a little bit higher than normal, but not really very elevated. But that, the reason why we are concerned about those is because sometimes people, when they do get pregnant, those values that were borderline, they become elevated. So we don't like to ignore those.
Right.
And the second part of it, you had some, we call those matching. It's histocompatibility, which means that histocompatibility between people, and there are certain findings between the partners that increase the chance of a miscarriage or an implantation failures. And you have one of those findings.
Okay.
And they lie into, to go a little bit more into detail, they lie between the certain receptors that are present on the baby, basically, and then on the placenta that affect the way the placenta and the baby overall interact with the place where the placenta implants, which is called the decidua, the uterus, basically.
Okay.
And there are some configurations of these genes which are called the HLA genes that increase the chance of a pregnancy loss.
Okay.
And you have that.
Gotcha. And that's
the third
true.
thing
Sorry, is that true irrespective of the baby not being genetically? It's just how it's the receptivity. It's a receptivity issue?
It deals with the DNA of your partner, of your husband.
Okay. I'm double donor, so I'm using the donor sperm, donor egg.
Oh, you're using that. So correct. Let me correct that. It deals with your ability to have that. We don't know their part, okay? But we know that your part is a higher risk.
Okay.
So it could be that they're low risk or that they are no risk, but you have that propensity. Let's put it that way.
Okay, so we're going to treat that to reduce that risk.
Correct.
Okay.
But it's an unknown risk, if you will.
Okay.
And then the last part is that you do have some anti-HLA antibodies, which are a sign of like a relatively active immune system.
Okay.
They can happen, anti-HLA antibodies, by giving birth. But you said that you gave birth a very long time ago, so they should be negative by now.
Okay.
So overall, that's the reason why we recommended, managing this. And honestly, if you hadn't had the losses, I would be less aggressive, right? Like the decision to manage a little bit more aggressively comes not just from the immunological finding, but also from the history, right?
Okay.
You got to put those together, right? So one doesn't. If somebody came to me and with your labs and didn't have any history of losses, one would be an NIVF failures. One wouldn't be as aggressive, but because of your history, that's what happens.
Okay.
And the last thing is this approval for the IVIG, which I know was a very unpleasant experience for you. But, the reality is that, these insurance companies, like, as you know, they are jerks a lot of the times. They don't want to pay for anything, but they also tell people, but if you change that, it works. It doesn't really work that way. You can't lie on it's almost like somebody saying, do insurance company covers breast augmentation? Well, they do in the context, let's say, of breast cancer. But if it's for aesthetic reason, then they don't cover it. And the doctor cannot do a procedure for aesthetic reason, and then lie and say it's for breast cancer. So
I just want to clarify. I do want to clarify. Nobody asked me to lie, nor did I ask anybody to lie. I just want to clarify that.
No, I'm not saying.
Okay.
I'm not saying. Hold on. Yes, sorry about that.
No worries.
So of course you didn't. I mean, I know that, but sometimes they will say, just change the diagnosis. But the diagnosis is what it is. You understand that?
Nobody asked to change the diagnosis. I just want to say that because I did have a tense conversation with the nurse where I asked her about idiopathic. Nobody asked me to ask about that. And then she went into accusing me of thinking of a fraud.
No. I think it was more like maybe she told you, like, look, we don't change the diagnosis because it is what it is. But, in any case, it's just a communication issue with these people, which is always annoying. But, we always try and unfortunately, we've not been lucky in general because it's outside of the realm of what they cover, unfortunately. You know what I'm saying? It's outside of the realm of what they cover. One of the things that we usually do if IVIG is not covered, we use, instead of IVIG, we use this drug called...
The Plaquenil. I have that. The Hydra... Yeah. Yes, I have it.
Yeah. Which is, there are studies that use one as an alternative to the other with success. You know what I'm saying? The reason why the report says IVIG is because that's like the standard, especially in Europe. In the US, is used less frequently, but most of the stuff have been done with IVIG. So, because the report has to present the standard, like the gold standard, but that doesn't mean that you're necessarily shortchange if you use the Plaquenil or the Neupogen instead. Yeah, I just want you.
So does that mean in the peer-to-peer they still declined it after further explanation?
They don't. Yeah, correct. They don't want to, deal with it. Mostly because it's already it's already used as IVIG is mostly used off-label.
Okay.
So you're already off-label and out of their indications, basically, Okay. So that's how they do it, So, and that's really where it's at with that. It's just like, honestly, IVIG is the kind of thing that gets really approved only if people have a full-blown autoimmune condition, let's say lupus.
Okay.
They also don't regard the current evidence in the use of IVIG for recurrent pregnancy loss as strong enough. They're like, well, it's still early, there's not enough research, blah, 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 blah. So that's another reason why they won't let it give it.
Understood. Are there studies that have conclusively shown improvement or no? Is it experimental?
There are, but there are randomized prospective studies that have, but not enough, I guess. But the societies that are responsible for determining the guidelines, like the American Society for Reproductive Medicine or the European Society for Reproduction, in their guidelines, they're like, yeah, we understand that these drugs are being used, but more studies need to be done. So they don't, for these guys, which are committees made of doctors, to actually say, all right, this is what we recommend for everybody, they need a lot more stronger evidence for that. And we may never have that evidence, certainly not in a short time, because not a lot of research is going on in this area, and so not a lot of money is dedicated to this field. There's no money in it anyway. So it's one of those areas where the progress is not being made that quickly. You understand that? So that's the other reason. So when they go look at the guidelines and the guidelines say need more studies, then you're stuck with that, right?
Okay.
Yep. So it's just like the way it is, with the way these companies approve stuff, and that's why we're not lucky in approving these medications, almost never.
Okay. I mean, as long as the effort was made, that's all I ask. As long as an effort was made, because you don't know until they answer you specifically, right? You can't make a general thing of like, they never do it because each patient is individual, right?
Oh, no, I understand that. I agree with you. Now, the other thing is that the ultrasound that you had, overall, the uterus is of normal size. I think there is a little bit of adenomyosis in the uterus, which is adenomyosis is like endometriosis, but in the uterus instead of like in the pelvis.
Okay.
But for somebody like you who's had multiple instrumentations of the uterus for pregnancies, and I don't know if you're, so I don't know if you have any symptoms. Do you have any pain or cramping or anything like that? But, you never had really any of that. So
Never.
overall, I would say that it's not something that makes me want to say, hey, we need to do any intervention or surgery or anything like that,
Okay.
To look for endometriosis or anything else.
You would need a biopsy, right?
I don't think it's necessary. I mean, visually, I think that's what it is. And as long as you've had a hysteroscopy that showed that the cavity was normal, which I'm sure that the docs at Columbia did.
Yes.
Because that's part of their protocol, I think you're okay with that. So my recommendation is to move forward with the Plaquenil, a low dose of prednisone, and the blood thinner, and then we're fine like that.
Okay. Is it the Lovenox is the blood thinner?
Right.
Okay. Okay.
So I will go forward with that plan. The only sort of caveat is that you have to be on the Plaquenil for, a few weeks before you start the embryo transfer.
Right. I started it July 1st, and the plan is to transfer in August. Okay.
Yeah, perfect.
I do have a question about the omegas, because the directions say like 2 milligrams and increase it, but the over the counter that was recommended to me is like 2,100 milligrams. So I'm not sure how to.
That's 2 grams.
That's 2 grams. Okay.
Yeah.
So then I would, if a dose is 2 pills, in order to increase it, I'd have to take 6 pills to start. Is that what you're saying? Every 2 pills is.
That would be 6 pills would be no. Wait a second. 3 pills would be 6 grams. That's it. That's all you need.
The dose is 2 pills is the 21. Let me get the bottle, because I just want to make sure that we understand.
Yeah, let's take a look. Yeah.
Because the recommendation is to start out higher and then taper it down.
Oh, I know, but you're starting at 6 grams, right? Can I see the bottle?
Yeah.
Yeah, so triple strength, right? So that's 2 grams.
So a serving size is 2 soft gels, right? So you're saying 2 soft gels is 2 grams.
That's 4 grams already, right?
No.
How much is one pill?
It doesn't have it by the pill. It has it by the serving size.
Okay, how much is a serving?
2 soft gels.
All right, then you take 3. Sorry, then you take 6.
Okay.
6 grams is the maximum daily dose.
And then taper it down, right?
Right, because 6 grams is a lot.
Okay.
You should be fine on 2 grams a day.
Okay.
After days.
After how many days?
After a couple of weeks, you should be fine.
Okay. Because let me just make sure. Oh, I printed it out. Yeah, okay, so 6 grams for 2 weeks, 4 grams for 2 weeks, and then 3 grams as a daily maintenance.
Exactly.
Okay, so start off with the 6 pills.
So it's 6 pills for 2 weeks, then you go down to 4 pills for 2 weeks, and then you go down to 3 pills for 2 weeks. 6, 4, 3.
Okay. 3 would still be, oh my God.
3 grams. Each pill is 1 gram.
Understood. Okay, I see what you're saying.
1 pill, 1 gram.
One. Yes, okay. Understood. Okay. Thank you.
Oh, good. My pleasure. Are you kidding me? Focus.
All right. I think I'm good then. Thank you, sir.
All right. Let me give you my cell phone number in case you want to get in touch with me in there.
Okay.
Because, you're in the middle of this. I don't want you to be confused or something. Just send me a quick text if there's anything, okay?
Appreciate it. Thank you.
Make a mistake.
Thank you. I appreciate it.
It was a pleasure seeing you in person.
Yes. Take care. Thank
right.
you so much.
Okay,
It was a pleasure meeting you. Bye-bye.
Bye-bye.
Baby. Okay. So Dr. Thornton is still there. This was the cleanup because I had sent that nurse a heated note about how she was unprofessional because she was like, we don't commit fraud. And I was like, who asked you to commit fraud? Who asked you to lie? Anyway, we're all good. Hopefully they really did the peer-to-peer. I already started taking the plaque one. I was just like, let me be prepared. So, all right, let me get back to work, girl. I'm excited. All right, pretty cool, right? So I think I'm in a good spot. If you have any questions about any of this, let me know down below. I'll talk to you later. Bye. Baby, that's to us all.